talk is on atypical variants of the BPPV. This morning, for next 15 minutes, I will be discussing some less common forms of posterior semicircular canal BPPV. Let's start with the title slide here only. The painted red is the left short arm posterior semicircular canal. The long arm of the left posterior semicircular canal is shown painted by green and pink. The recessus ellipticus, which is shown here, is a transversely oval depression in the vestibule's roof, which occupies the central part of the bony labyrinth of the inner ear. It functions to detect the linear acceleration and gravity because it houses the utricle and saccule. It is divided from the spherical recess, that is the saccule area, by the vestibular crest region. The otoconal debris, which remains normally embedded into the gelatinous matrix of the utricular macula in the recessus ellipticus, sometimes gets disengaged and it drops off and reaches the periamplar location of the long arm, resulting in the typical periamplar posterior semicircular canalolithiasis that we normally treat with the Apley or Simond maneuver. However, sometimes it gets disengaged and get entangled in the non-ampullary arm near the crus commune, resulting in the apogeotropic posterior semicircular canal BPPV, that is one with the downbeating contratorsional positional nystagmus during the Dix-Hallpike testing. The otoconal debris, which you see here embedded in the recessus ellipticus utricular macula, if it gets disengaged, one would expect that it would drop off into the short arm. This is indeed one of the mechanisms, but less common. However, more commonly it is seen in early retests, that is the patients in whom you have done a Apley maneuver or Simond maneuver and they present next day or a few days later with residual dizziness, mainly sitting up vertigo, because the otoconal debris which you had tried to relocate or reposition back to the utricular macula, instead of getting embedded into the utricular macula, it slips off from there and reaches the short arm. So this is an intracanalar migration from the periamplar location to the short arm, resulting in the dizziness. With this, we start with the apogeotropic two cases here. This is the location of the otoconal debris in the apogeotropic posterior semicircular canal BPPV, which is an unstable location. Why? Because if the patient lies supine, it is expected to convert into the typical periampullary posterior canal BPPV variant, and if the patient bends forwards or lies prone, it is expected to autocorrect, but it seldom occurs like that because a narrow semicircular duct or a large otoconal clot or both, that is a partial canal jam, is almost always present in such patients, and it has been clinically demonstrated also by few researchers by the video head impulse testing. So what are the clinical consequences of such a partial canal jam? Non-positional disequilibrium of unilateral hypofunctioning labyrinth is almost always present in such patients, and it is relatively difficult to reposition. So what to do? Transform from the non-ampullary to the typical periampullary variant, cases 1 and 2. This is the case 1, 62-year-old male came with the history of positionally triggered disease spells for past 2 days. The first Dix-Hallpike test shows a slow crescendo decrescendo downbeating left torsional nystagmus, implying involvement of right posterior semicircular canal, that is a canalolithiasis in the non-ampullary arm near the crus commune with a possible partial canal jam. What did I do? Hyperextended the neck and repeated a right Dix-Hallpike test. So now it shows a upbeating right torsional nystagmus, implying a intracanalar migration of the non-ampullary to the periampullary location. So this was successfully treated with the right Apley maneuver, and 24 hours later the patient did not have any nystagmus and accompanying vertigo. Case 2 is a 53-year-old male came with the history of positionally triggered disease spells for past 4 days. The left Dix-Hallpike test after a latency of 30 seconds shows a downbeating left torsional slow crescendo decrescendo nystagmus fast forwarding it to that side, and there you see a downbeat nystagmus, slow crescendo decrescendo. The upper poles of both eyes are torsionally beating towards the patient's left ear, implying that this gentleman suffers from the right-sided apogeotropic posterior semicircular canal BPPV. What did I do? Because it was a right side, I did a right-sided side-lying test, which is shown here. After a latency of 8 seconds during this right side-lying test, patient elicits a upbeating right torsional nystagmus, implying intracanalar migration of the otocondylar debris from the non-ampullary region to the periampullary location, and this was successfully treated with the Apply maneuver. How does this happens is shown here. With the head turned 45 degree to the non-involved left side and short sitting, the patient is taken briskly from the position A. The otocondylar debris position is in the position A is shown in figure D. So the result could be either it reaches towards the near the periampullary location, or it can sometimes reach directly the periampullary location as occurred in the previous case. So the clinical pearl is that neck hyperextension during a repeat Dix-Hallpike testing or carrying out a side-lying test opposite to the torsional component of downbeat nystagmus may convert non-ampullary posterior semicircular canalolithiasis into the typical periampullary posterior semicircular canal BPPV. If it doesn't convert, what to do? This is the damage cement maneuver for the right-sided posterior semicircular canal BPPV of the apogeotropic type. Damage cement maneuver for the right-sided apogeotropic posterior semicircular canal BPPV. The patient is seated in short sitting like this, hands crossed. We put the head 45 degrees to his left and we take him down briskly. So we do it couple of times. In my practice, I do it for 10 times and ask him to lie in 45 degree force prolonged positioning like this, which I am showing here. We normally lie on the left dental recommend, but this is 45 degree force prolonged positioning with 45 degree nose down. If the patient keeps a iPad or phone here, he will be watching some show or any program for 1 hour, and that will be helping. This is called 45 degree force prolonged positioning. So case 3 is right short arm posterior semicircular canalolithiasis that I discussed in first slide is because of early retest, but this was interesting because this was a de novo case. The lady is a 48-year-old female, came with a history of vertigo for past 7 days. The left Dix-Hallpike test did not show any positional nystagmus during 1 minute of observation. So I am fast forwarding it to 30 seconds, no nystagmus, 51 seconds, no nystagmus, 1 minute and 10 seconds, no nystagmus. So what did I do? From this position, I anti-flexed the neck around 60 degrees, taking it 30 degrees above the horizon and making it a half Dix-Hallpike position on left side. Now this elicits an upbeating left torsional nystagmus that was persistent, lasting more than a minute. When the 1 minute elapsed, I transitioned her to the right lateral recumbent with nose down. If the nystagmus disappears, then it implies that the otocondylar debris, which is on the utricular side of the, that is the short arm side of the left posterior cupula, is non-adherent and it falls back into the short arm, and that is the short arm posterior semicircular canalolithiasis. So what did I do with this patient? The clip speed is increased 3 times. Prone positioning with the head coming out of bed from the short edge. Vertex facing the ground. The head was briskly shaken at 3 cycles per second, side to side for 1 minute, and then kept in this position, the vertex facing the ground for another 1 minute. What happened after 24 hours was extremely interesting, and this has been reported only twice in the history of neurology. Left Dix-Hallpike test was repeated after 24 hours. At 24 hours, the left Dix-Hallpike test elicited an upbeat left torsional nystagmus, implying a transformation from short arm to typical long arm periampullary posterior semicircular canalolithiasis, which was subsequently successfully treated with the left apple maneuver. So, how did that happen? The otoconal debris, which was in the short arm of the left posterior semicircular canal of this woman on day 1, during the prone pitch and yaw maneuver, instead of getting embedded into the utricular macula, the debris shifted towards the common crus and reached the long arm. As the patient was uprighted from the prone pitch and yaw maneuver, the debris reached the periampullary location. So BPPV should not be classified as subjective after a negative Dix-Hallpike test without auxiliary positional testing. And these positional tests, which are called auxiliary positional tests, are half Dix-Hallpike test or augmented half Dix-Hallpike test. The same applies to the retesting after a presumptively successful Applet or Simond maneuver in patients with residual dizziness, especially the sitting of vertigo. Case 4 is my last case. Right posterior semicircular cupulolithiasis. This is a lady, 63-year-old A&M, came with the history of positionally triggered disease spell, which started in the morning as she got up. The right half Dix-Hallpike test after a latency of 30 seconds elicits an upbeating right torsional nystagmus that was persistent, lasting around 1 minute. So after completion of 1 minute, what did I do? As you can expect is that an inversion test, positioning to left lateral recumbent with nose down, and expecting either the nystagmus would cease or reverse its vectors. The nystagmus now you see is downbeating, and the upper poles of the eyes are torsionally beating towards the patient's left ear. So the nystagmus vectors have reversed directions, both vertical as well as torsional, implying right-sided posterior semicircular cupulolithiasis. A positive inversion test is the acid test for posterior semicircular cupulolithiasis. How does this happens? In the right half Dix-Hallpike position, there is a excitatory ampulofugal deflection of the right posterior cupula, resulting in the upbeating right torsional positional nystagmus. As the patient is positioned left lateral recumbent with nose down, there is a ampulopetal inhibited deflection of the right posterior cupula, resulting in downbeat and left torsional positional nystagmus. What did we do? The bascule maneuver, innovated by brother Andrea Castellucci from Kittley. The patient in short sitting, the head yawed 45 degree to her non-involved left side, briskly taken to the demi-Simond position, maintained in this position for 15 seconds, and then a reverse Simond maneuver very briskly, and then again a Simond maneuver, that is 180 degree sweeps, Simond and reverse Simond. During the 11th time, that is in the nose down position to her left, she had a severe vertigo. This was taken as liberation of otoconia into the utricular macula, and then she was uprighted, terminating the maneuver. 24 hours later, half Dix-Hallpike test was repeated. No nystagmus at 30 seconds, no nystagmus at 1 minute, and no nystagmus at 90 seconds. Patient is free of vertigo. This is the original paper which I reported with Andrea Castellucci. He was made the first author because his publication is still in pipeline. Bascule maneuver was described in 15 patients. Clinical pearl is that in carefully selected cases, the vestibular maneuver provides a simple and rapid physical therapy approach for effectively treating patients with posterior semicircular cupulolithasis, provided that the vestibular therapist is physically stronger than the patient and the patient is fit to undergo such a brisk maneuver. I finished my talk here. Thank you very much.